Welcome to Sex Tales, the podcast where we sort of normalise all things sex and relationships. And today I'm joined by the wonderful Clare Bourne, who is a pelvic floor physiotherapist and also the author of the book Strong Foundations. Today we're going to be talking about sex and pain and the interaction between those two things. So I'm really happy to have you. Thank you, Clare.
Oh, thanks for having me. I'm excited to chat.
Yeah. Obviously, as a psychosexual therapist, I'm often dealing with pain very much from the thought process of that it's not a physical issue. And obviously you're dealing with it often from the other side. So I suppose in the first instance, as a pelvic health physio, what generally are you going to be treating? Kind of when people come into your clinic, what's the focus when it comes to sort of pain and sex?
Yeah, great question. I mean, often they'll come in with a mixture of things. It may not even be just related to intercourse, but then through the conversation, you realise there is some symptoms there as well. But the majority of sort of conditions would be, they would say, oh, it's painful to have intercourse or it's not possible to have intercourse. From a medical perspective, we would call that dyspareunia. So that's pain with intercourse. And then maybe different subconditions that we would notice. So it might be related to a vulval skin condition. So obviously that would need treatment with a dermatologist as well. But then if we've got, say, a skin condition, which might be related to being postpartum, it might be related to a tear from birth, it might be related to menopause, it might be related to a diagnosis of a skin condition like lichen sclerosis or lichens planus or eczema or something else. There may not be so there's that as a fundamental, but there may also then be an overlay of pelvic floor response that we would call vaginismus, which is the involuntary contraction of a pelvic floor to penetration. Now, that may have started for so many reasons. And then there might be something more called vulvodynia, where there's also a nerve element. So I say those are the three main categories we generally would see that would relate to pain and intercourse.
Okay, all right. And obviously I'm very well aware of those because those aspects come into my clinic all of the time, and I'm trying to navigate kind of obviously what's physical and what's not. In terms of kind of men that might come to you for kind of those sorts of reasons, why would men come into the clinic?
Yeah, great question. So that might be related to kind of change in their erectile function. This might be after a surgical procedure, or it might not be. It might be in younger life. Also, men who are struggling with premature ejaculation, which again we know is complex and very mind-body, but they might be interested in exploring whether there is a physical component to that as well. We also see men who maybe have sort of penile pain or testicular pain. I've treated men after sort of testicular cancer where they've had surgery and they've got scarring, and this has also then led to kind of pelvic floor pain or kind of more generalized pelvic pain or post-ejaculatory pain. I mean, it's such a broad area, and something I think we only touch the surface of when it comes to the physical muscular involvement of intercourse for women and men.
Yeah. And I know it sounds like a really obvious question, but kind of when we're talking about the pelvic floor, we talk about the pelvic floor and pelvic floor health. What are actually we fundamentally talking about? And why is it so important, and what's the kind of misunderstandings about that?
Yeah, I love that. So essentially what we're talking about when we hear about this term, the pelvic floor, which you're right, it's almost like mystical, like where is it?
Yeah, yeah.
So every human skeleton has a pelvis, and then at the bottom of the pelvis is like a circular ring that's open, essentially, of the bony structure. What fills the whole of that is the pelvic floor. So it literally is the floor of the pelvis, but it's made up of muscular tissue, contractile muscular tissue. So a skeletal muscle like a bicep, a tricep, a quadricep, a hamstring, that we would understand as bodily movement. It's the same sort of structure in the sense of the muscular structure, but it's made up of lots of little muscles, including the sphincter of the urethra and of the anus, which obviously control our bladder and bowel function. And then obviously for the female, it's around the vaginal opening as well. So it's quite a broad group of muscles. For women, it's sort of like the size of both of our hands, together. Is the best way to think of it. Men, it's a slightly more tighter structure. Obviously, they don't need to be able to birth a baby through it. So they've got a slightly different bony structure to us. And therefore the muscles represent that as well. But that's essentially where it is. And I think we often don't think of it as a muscle that we have control of. It's sort of like our genitals. So it's just like a separate thing. But actually, it's a muscle that will respond to day-to-day life. It will respond to our kind of our feelings, our thoughts, our emotions. And we have research that proves that as well. So it's a very dynamic muscle that's really at the center of us and responds to an awful lot that it experiences through day-to-day life.
Okay. I suppose the kind of thing for me is, I mean, obviously I know you, I know your work, I know how it interacts with what I'm doing. But I suppose the idea that people might have some of these dysfunctions, all these pains, and then would think, oh, actually, maybe I should go and seek the help of a pelvic health specialist.
Yeah.
What are the majority of what are generally people coming in for, and what's the split between genders?
Yeah. I mean, so to be clear, not all pelvic health physios treat all genders. So I'd say traditionally it came out of very much a female focused profession. And I'd say it's only within the last decade it has become much more of a thing to treat men. I've just always treated both, and I also treat children. So I've always treated all ages, all genders. And obviously, we also have the transgender community, the non-binary community, which, if I'm really honest, I don't think as a pelvic health sort of community we're massively supporting very well at the minute. And that's partly because we don't have any training in supporting people necessarily, especially if they've been through surgery.
Yeah.
So I want to identify that obviously gender doesn't always for people mean male and female, though obviously anatomically that's sometimes what we're dealing with. So I think from a who do we treat? I mean, we really treat anything related to bladder, bowel, sexual function. Now, through my experience, I've always worked in very sort of psychosexual focused teams with a lot of dermatologists and gynecologists. So I'm really passionate about it, and I've been exposed to a lot of supporting people across my career. Not everyone will have had that, and so they might more work just with the pre and postnatal community, or just females, or just athletes, or just urinary symptoms rather than bowel symptoms. So it's just I want everyone to know that we don't all necessarily treat everything, and some of us will have more passion in some areas.
That's really
I'm just very passionate.
That's really
about
helpful to know. Yeah, absolutely. And I suppose in the same way that I do, I have particular focus in my work, obviously, even though
Absolutely.
I can look at all of it.
Yeah.
We're talking about sort of pelvic floor in terms of sex and pain, but what about sex and pleasure?
Yeah.
Can you tell me about the interaction between those two things?
Yeah, absolutely. Gosh, this is the stuff we're just never taught, are we?
No.
And I think it's so fascinating. I mean, look, I don't think we're even taught about our anatomy. So we're expected to have this amazing sex life, and we don't really even people don't even know where the urethra is, where the clitoris is, what's the labia, what's not the labia, what's the vulva, what's the vagina. So, for me, fundamentally, I always say to people, understanding your anatomy has got to be primary.
Yeah.
And also, like, men and women, like, it's very different. Men's anatomy is right there in front of them. They can see everything. They can feel everything. As women, it's very hard because you can't easily see. So there's a big difference in that of just connection with the body. But from a pleasure perspective in these muscles, essentially they have to be relaxed enough to allow penetration, depending on what that is. And then they need to sort of be mobile and strong enough to then respond to orgasm. So at orgasm, there is a sort of this rhythmical contraction generally of the pelvic floor muscles, which people don't necessarily identify as being a muscular thing, but it's almost this like rhythmical kind of contraction that often people can feel. So it's very much part of our pleasure, but it's also very much part of allowing it to happen. So, like, such an important group of muscles. And I often say to people, if nothing else inspires you to do your pelvic floor exercises, let it be that it's part of sexual pleasure. But yeah, there's no real understanding of that. But I think also within our sex education generally, and I'm sure you feel the frustration of this, there's no focus on pleasure. It's not focused on being a positive thing. It's very much on like, don't do this, don't do that. Not celebrating how it could be positive and how that could be done well. And I just think if you don't have that basic of understanding of anatomy and physiology, just doesn't have to be on a complex medical level. Very hard to build.
Yeah, I mean, absolutely. I mean, I think almost, 70% of the time I'm actually, when we're talking about pain or we're talking about desire discrepancies, which is a consequence often of pain, I'm going back to basics about the anatomy and actually getting, it's amazing how little we don't know. And obviously there's a shame in not knowing, when actually it is just about going back to basics about that education, and it's completely, okay.
Totally.
Obviously, one of the things that I talk to a lot, again, with my clients is about the tension that they're potentially holding. The tension that they're holding. And I suppose the question for you is how do you determine what is kind of ongoing tension and psychosomatic? I'm worried, I'm holding myself because I'm concerned about what might come, and actually what is, I suppose, tissue or muscle, or actually, how can you tell which is which?
Yeah, it's a great question. Yeah, a lot of it for us comes from like the history and understanding like where did things begin? What was your first experience of that? Um, Obviously our assessment as well. So as pelvic health physios, we're doing internal examinations. Obviously, if the person is happy for us to, and it may not be appropriate on the first assessment, it may not be appropriate for many, many assessments, but there's lots of ways that we can sort of support. But, as a clinician, what I'm looking for is what's sort of the resting tone of the muscle? Like what's it doing just as we're lying there supposedly relaxed? Though I appreciate most examinations in a medical setting don't feel massively relaxed, but we talk about how to kind of allow the body to do that. Obviously, with the history of, say, if someone's also got maybe some history of perineal trauma through birth, then there might be some literally like scar tissue that's actually creating a restriction of a muscle. So through the information that you gain from your talking assessment plus the physical assessment, we then try and work out together. I'd say it's often very much a bit of both, in the sense of that, like, you look at all around the pelvis as well and see how are other muscles behaving and interacting. But if, say, there is a longer history of a pain with intercourse, the reality is it can very much change muscular behavior, not on a conscious level. And that's why I'm very clear with people. I'm like, I know that you're not sat there thinking, squeeze my pelvic floor. It's very much like a learnt protection. And we often describe the pelvic floor a bit like a bodyguard. Like it's trying to protect us. So what it's trying to do is very clever. It's sort of being like, this isn't safe for me. This doesn't feel okay for me. And I'm going to try and sort of withdraw so it's not possible. Unfortunately, that then can create more pain, which then creates more issues, and we end up in a spiral.
Yeah, and compounds it.
Exactly. So a lot of the time it's just us trying to be like, well, this is what we're seeing. This is what we found. This is the history. And obviously if there's a skin condition as well, then that's a whole other thing that we have to deal with. But there might also be urinary incontinence, which is then irritating a skin condition, which is then also causing pain with intercourse. So then you're trying to work out, okay, so which bit are we dealing with first? It might be that we need to really get that urinary incontinence under control, look after the skin, and then as a secondary, come and then work on that tone. So yeah, it's always a bit like just chicken and egg. And I always say we're detectives, we're trying to understand more so we can help you understand more. And that's a journey. In the same way with therapy, it's a journey which we don't always fully understand, and we don't always ever fully understand, but we can come with what's going on right now. I think when you're living with pain, you want to know that one thing that's causing the pain.
Absolutely. And it can be really frustrating, can't it?
Really frustrating. Because it would be lovely if you could just be like, it's all my pelvic floor, and if I just sort my pelvic floor, the pain will go away.
Yeah.
But the reality is, as you know so well, is that as a body, we're a constant interaction of so many things. And obviously, the way I talk about in clinic is that you're then coming into a relationship with somebody potentially, or an interaction with all of their stuff as well. So you're dealing with all of this going up and down. They're dealing with all of their up and down, and then you're also doing crosstalk. So I always love to just sit down in clinic and talk about what we would call in medicine the biopsychosocial model of care. Whereas, like, yes, it's a Venn diagram for anyone who's listening. It's like there's biology, which is obviously very much my thing, of your muscles and your nerves and all of that. Then there's the psychology, which is obviously your bag, where you're thinking about all that mind, emotion, previous experience. And then there's the social of like, gosh, work was awful today, or I had an argument with my partner. And all of these things feed into our experience of pain. And therefore, it's impossible just to be like, well, it was just my pelvic floor, because your pelvic floor will have responded to your psychology and your social.
Exactly.
And they all interplay together.
Yeah, yeah. So you were talking there kind of about the assessment and, you know, and then kind of the process. And I suppose obviously it's different for everybody, Claire, but just kind of just for people that might be listening so that they understand what might the assessment look like, how many assessments might you take, how long is treatment generally, you know. And again, I know that's sort of broad brushstrokes, but I know people ask me the same question in terms of what am I actually practically getting when I come into the clinic.
Yeah. So I would say first as well is that, like, even from an initial perspective, some women don't feel safe to come into clinic because they're just like, I'm not sure I'm there yet. So I do run virtual consults where someone have been like, I know I need to engage with this, but I just can't come and see someone yet. So if that feels safe for you, we can go virtually. We can do a lot of the initial assessment, a lot of the talking, a lot of the breath work, a lot of that virtually, if that's what someone feels safe with. Yeah. Then obviously from a physical, if we met in person, so it's always a chat first, like getting to know you, understanding. I'm always going to like give you loads of space to share your story. I'll ask specific things to try and understand from my brain where things are coming from. And then the physical assessment, as I say, this would be a routine, but again, we will only do what we discuss and you feel comfortable with. And often by the time I've chatted with you, I'll probably understand what is and isn't okay for you. We'll look at your diaphragm, we'll look at breathing, we'll look at the abdomen. There might be that you've got some scarring from previous surgeries, so we consider everything in that regards. And then an internal check will often involve with just looking at the vulva first. Again, I'm looking for vulval skin changes. I'm looking for any areas of cutting or splitting or anything that might be contributing to your pain. And then an internal check for me isn't with a speculum in this regards, because I think that's what people are worried about. They're like, well, we can just like shove something in here and make pain. Yeah. We use one finger. We insert that into the vagina and then we're tracking through the pelvic floor. Obviously, for men, we do an anal rectal examination. And for some women, that might be appropriate as well. But then we're based on looking at, again, muscle tone, what's going on with those muscles at rest, how much can you interact with those muscles, can we change that muscle through breath, can we get you to feel it? And that would be the whole initial assessment and give you a program to start working on from a muscular perspective. We might then follow up with things like self-massage. If there was a scar that needed addressing, we might involve vaginal dilators. I hate the term, hate the name, think that's really misleading.
What, the dilators?
Yes.
I agree. I almost hold my breath when I ask clients to start with dilators. And I'm totally with you. They should be renamed.
They need to be renamed. I'm like the pelvic floor trainers at the end of the day. Your vagina, which is the inside tubey area, doesn't need dilating. That's not the issue here. And actually, the vagina is phenomenally designed with what we call rugae, which are like wrinkles on the wall, which basically make it like an accordion so it can stretch. So I'm always like, your vagina has plenty of space in there. We don't need to worry about that. What we're really talking about is the muscular and the tissues on the way into the vagina that need retraining to the concept of penetration.
Yes.
So often I find dilators are just banded around and women are almost re-traumatizing themselves by trying to shove things in. They don't have any guidance. They don't really know what they're doing. So I'm always, when women are like, no, I've tried them, they're awful. I'm like, give me another shot and let's do this properly. Because when we do the like mind, body, breath work with the dilators and we understand the context, they're absolutely phenomenal.
I absolutely agree. But I reckon you've also got, you've got a brand opening right there, haven't you? after the book, you need to do the Clare Bourne pelvic
Bourne dilator.
Yeah, trainer, something.
Trainers.
So, are there any kind of sex-related symptoms that people might not actually realise is potentially related to the pelvic floor, or just have, not even connect those two dots at all?
Yeah, I mean, I think a lot of the time with pain, that is the biggest one. They just don't understand their pelvic floor might be involved in it. And I think even our medical system doesn't, if I'm really honest. You go to the gynecologist tells you everything looks healthy and fine. And that's when the woman then embodies, or a man embodies this like, oh, well, it must all be in my head then. I couldn't physically have anything wrong with me. And That's a real problem. If we don't, again, it comes back to that understanding of physiology. Like, if we don't really understand the role of the pelvic floor within sex, it's very hard to understand the concept of it being involved in maybe a problem. Um, so I would say pain is a big one, or anorgasmia, like no pleasure, are big ones. Like, I just don't really enjoy it. And obviously that is always complex.
Mm.
And for me, with all of the clients that I work with in this field, the majority of times I am recommending that we co-manage with someone like yourself, because though I have some basic psychological training in this area, just to make sure that I was doing things appropriately and could identify things, I'm not psychologically trained. So it's really important that, and to be honest with you, I think this would benefit from this if we just were more open to this. And I think the mind-body conversation is hugely growing at the minute within our healthcare space, which is like finally where we needed to be. I always say to people, it's completely impossible to cut your head off from your body, because your nervous system is completely integrated and all these messages are going through the brain. So it's never saying that it's one or the other. It's saying that there are drivers from both, and that interaction is what we need to understand more. But yeah, I guess from my side, those are the main two camps. It's probably pain or an inability. And I literally love the emails that come through when people are like, I had sex for the first time. It was amazing.
Yeah.
Those moments are just phenomenal, that someone's been so vulnerable to come and share their journey and you've been able to be part of that.
Yeah.
It's amazing.
How long might a journey, last? Like, how long might somebody be in treatment?
Yeah, it's a great question. To be honest, there really isn't an exact. However, I mean, I've had some women who've come and it's literally after 2 sessions, they're like, oh my gosh, I'm literally fine now. Like, I've sorted this out.
Okay.
Really quickly. And for other women, I could be treating them for like well over 1.5 years, or it might be there's a bit of a, bouncing backwards and forwards between, okay, I need to go and deal with some psychological stuff that has now come up. Sometimes it's very hard for us to know what is the main driver. And sometimes when we start on a journey, and as you'll understand with psychology, sometimes there's a lot of stuff that's been kind of pushed away that we may not even remember. And then as you start to talk about these things, more stuff comes up. So sometimes the journey can be very weaving. And I'm always like, look, this is what I want you to work on, but I think we need a bit more psychological support to help with the stuff that's coming up. Then maybe we'll move on physically. So that it can be a real kind of like, not a quick thing. It can take quite a while, but with the right professionals at the right time. I very much the way I work as a clinician is you're not dependent on me to do the work. So it's very much like even if I saw someone for 1 year, I'm not seeing them every week for 1 year. It's very much like, we do our check-ins, we regroup with what's going on, we progress, we do homework, we come back. A lot of the time I think it's this accountability of support of, I've got to do the work. I'm going to go and see someone. We're going to check in and we're going to progress. Because it's easy to be avoidant of this stuff because it's kind of not that nice to do. I always say to women really transparently, no part of you after a busy day is going to want to lie down and use a vaginal dilator and do breath work.
Exactly.
You're going to want to disassociate. You're going to watch Netflix and you're just going to want to deal with your day and move on. So it's going to take commitment and it's going to take energy that you may not really feel like you have. And I'm here to be your cheerleader. I'm here to be your teammate and I will check in with you. And that's my role, but it's very much not, you're going to come here, I'm going to magically manipulate you and everything's going to be better again, because it's a deeper work than that. It's very different physiotherapy to I've got a tight bottom muscle, let me just put my elbow in it and then off you go. It's a very different thing. Now, saying that, we might do some internal release work of the pelvic floor to help someone connect with that release and let go. So I'm not saying there won't be some hands-on treatment that might be appropriate, but that's got to be determined as appropriate for the individual in front of us with their history and everything they're dealing with. Because understandably, within this community, there can be an awful lot of sexual trauma as well.
Yes, exactly.
Previous abuse, maybe not even consciously aware of. And so it's really important for us as clinicians that we don't re-traumatize anyone through a process of hands-on treatment. And there are some women that I don't really do any hands-on treatment, which I know people are like, what? You're a physiotherapist. But that's not appropriate for everybody. So it's very much like, as a clinician, you're determining with that person. And I always say to people, you're the boss, right? I'm not here to tell you what to do. I'm here to work with you, and we collaborate on what the research says, what you're saying, what your life is, what the interactions are, and we will make an appropriate plan for you thereon.
Yeah, I really like that. And to be honest, I think, your ethos is quite similar to mine in that, I feel I'm here to mirror back to you. I'm here to mobilize you, but ultimately I can't do the work, I can't do it, but I can, my job is to get you from A to B and yeah, with a holistic approach. So, yeah, I mean, on that, obviously, it takes, and as we both understand, it takes quite a significant amount of time to actually approach a psychosexual therapist or a physiotherapist. It really does. I mean, sometimes I talk to people and it's taken them 3-4 years to be able to, to come to therapy. And obviously, I think we both have some understanding about what those blockers are. But could you just talk to that in your experience a little bit about what the barriers are to people seeking help?
Yeah, gosh, so many, so many. I think, societal shame, that it's sort of still a bit like we don't really talk about sex. There's a lot of normalization of stuff that we don't really know because we don't really talk to people. I remember at university talking to friends and they'd be like, "Oh, I don't really enjoy sex." And I was like, "What? Like, is that normal?" There's a lot of like, and we don't really model that. Again, it goes back to that very young education.
Totally.
So I think that's a barrier, that it's just not ingrained in us to come and chat about these things, and I see that very generationally. I'd say the generations coming through now that I support in their 20s are much more open than the women that I treat in their 60s who are still like, "Oh, down there, oh, intercourse." So I think we're getting there, but that's a big barrier still. Accessibility is huge. Let's be honest, accessing this support on the NHS is really, really tricky. And I know that from being married to an NHS GP. He has these women that are desperately seeking this support. And he's there calling me being like, where do I refer? Like, I haven't got a pathway. And then even if you do get in, there may not be the psychological support that the physios are then feeling like that you need, or the waiting list might be a year or so. I know I've had a client who's been waiting for psychosexual support for like 2 years. Now, we've done a lot of, maybe longer. We've done a lot of good work, but I've always been clear on like, there are a few things here that I really need you to go somewhere and talk through. So that's a huge barrier, which, then leads people to a financial barrier, that if you can't access it on the NHS, you're very dependent on funding it privately. Even if you have insurance, a lot of insurance companies will not see it as a sort of a fundable thing, because it's not necessarily like, a medical thing that needs medication or treatment in that way. So it can be, depending on your policy, they can be very much like, well, why would a physio be helping you with that? And, as you'll know, psychological support through insurance is generally quite poor and very limited. Like, you might get 5 sessions, but as you know, you're probably scraping the surface by the 5th session.
Yeah, I mean, when I was at the NHS, I mean, the limit was, 6 sessions, and then you would have to apply for more, and there would have to be good reason for that. But averagely, by the time they'd got to me, they'd been waiting a year and a half. Somebody with compounded issues around vaginismus, pain during sex, erectile dysfunction, like, it's only compounding the psychological effects that are already happening.
Totally. And unless that's coming together, and unless there's that collaboration, it can feel very frustrating for the patient of like, is this a waste of time almost? Because I really need, part A to work with part B. I don't think it is ever a waste of time, but I think it can feel very frustrating that the system isn't set up for, like, in my opinion, what individuals really, really need. And as you know, I worked in the NHS for years, and I'd always find it so frustrating where I'd be like, I could tell you everything I want to do for you, but I'm so limited.
And then that leads it into the very real thing that it becomes a very privileged position, and so then we're treating one group. And that, for me, I don't know about you, but I find that very difficult. And of course, I offer low cost and I offer concession work. I try and do things like this so that I can be more informative and help people with understanding more that might not have otherwise had access. But it's a problem. it's a problem. And as we know, gynecology, I mean, it's just like it's fallen through the floor. The wait time at the moment, I think, is like 2.5 years.
No, but it's true. Even with men, like, I have so many men that end up with me, finding me on YouTube because, they've been to the urologist who again have told them there's nothing wrong. And they're like, "But I've got a real lived experience here of something being wrong with my body." There's no one even saying maybe go and see a pelvic health physio. So they're like manically Googling and trying to find people online. So, accessibility is a real issue. And will it ever change? I don't know. That's the thing. I think awareness is increasing, which is important. I think awareness has to increase in order for there to be change. But even within our sort of community of those with endometriosis and adenomyosis, I mean, look, it's only the last few years I feel like we finally people actually understand these conditions as what they are. Finally, we've got more campaigning about it. But painful intercourse can be a huge thing with that community. Um, and then, but then I've had women come to me being like, well, they're not interested unless I'm actually trying for a baby, but I can't actually try for the baby because I can't have intercourse, but I don't want a baby right now. But if I don't try for a baby and it's fertility related, it's almost like they're not interested. And then as an individual, you're feeling, well, if I'm not procreating, like my pleasure and my experience of relationship isn't important enough. It's so hard. I get it from a funding perspective because I've also sat there as an NHS manager looking at funding, and it's an absolute headache. So, I don't say this in a criticism way. I just say this in I'm slightly
absolutely,
heartbroken.
I don't. It's just what do you do? I think that when your whole job and being and center of gravity, your values are about helping others. I'm passionate about helping others. I want to make sure that people have pleasurable, sex lives and relationships, and that it doesn't feel so stigmatized, and that they come to me. But yeah, it's more and more that it becomes a privileged position, and I don't feel it can't be like that.
No, I understand that.
The thing that I also wanted to ask you was obviously the sort of pain, sex, during birth, during pregnancy, and at post. Now, I am a woman that is childless involuntarily. I was diagnosed with endometriosis when I was about 22. And I've gone at that time. I mean, I'm 50 now, and at that time, I didn't even know what that was. And there was no treatment, and it was just like, yes, that's quite difficult, and you probably can't get pregnant, and that was kind of the end of it. That was the sort of the end of my story. So I suppose I'm asking you because actually I don't have a lived experience of that, but obviously I know it's the big body of your work, and it's a big body. It's a lot of the reason my clients come in. So yeah, can you just talk a little bit to sort of pain during pregnancy and what's happening physically, and then post pregnancy?
Yeah, absolutely. Yeah. So, I mean, what a wild ride all of that is. So I think, again, we don't really, a lot of the time we don't talk about this stuff. So in pregnancy, we go to a really high estrogen state. I mean, let's talk about just the experience. A lot of the time for about 6-7 weeks, you're feeling horrendous. So the thought of really being intimate with somebody else when all you want to do is throw up is not top of the list, and you feel more exhausted than you ever have. So there's lots of barriers from that perspective. From a physical perspective, what's going on physiologically is you're going into this very high estrogen state. So actually some women feel like really turned on and really want to have intercourse, because actually their whole body is in this estrogen, like, love it kind of stage. And obviously we know that if you have a natural menstrual cycle, often it's around ovulation that you will generally naturally want to have sex, because it's almost like your body is wired that way hormonally. But some women are just feeling so uncomfortable. You've got your boobs have got much bigger, your belly's getting bigger, you don't necessarily recognize your body, and therefore that can feel like a barrier. From a vulval perspective, you end up with a very much more swollen vulva, and women come to me being like, "Oh my gosh, Claire, what is going on down there?" And I'm like, "Don't worry, it's normal." But again, no one tells us, "Oh, by the way, there's a lot more blood flow. Your vulva's going to almost like swollen and big. You can end up getting varicose veins," which are like literally what they say, a varicose vein in the vulva, which obviously a tiny little area, lots of nerve endings and a swollen vein, often quite sore. So there might be lots of reasons why it might be sore, but you might actually have a great sex life in pregnancy and actually want to have sex more than ever. So it's quite a kind of stark thing. And sometimes people psychologically are just like, that feels weird, having intercourse, baby's just there, and sometimes partners are like, I'm worried, or there might be medical reasons with regards to concerns of the placenta or your cervix that you might be advised against it. So that's kind of pregnancy. I find it's a really mixed bag. I guess the other thing with pregnancy I would say is if you've got a history of painful intercourse, but you have fallen pregnant, whether that's through natural means, IUI, IVF, it's a really good thing if you're wanting to have a vaginal birth to try and see a pelvic health physio, so we can just understand, was any of that pain related to pelvic floor tone and tension? Will that relate to birth at all? That's things we need to think about. So that's sort of pregnancy. Then when it comes to birth, I mean, it's a very common misconception that if you don't have a vaginal birth, your vagina's are good and there's not going to be any issues. But actually, I mean, if we go for vaginal birth, the majority of women, and especially first-time pregnancies and births, will have some degree of a tear. So whether that's to the sort of superficial tissues, the skin, or into the muscles. And obviously having a tear in a very sensitive area and then it healing, it can be quite tight, it can be quite sore. But the big part of this conversation, which we don't talk about, is you go from this very high estrogen state to a very suppressed estrogen, low estrogen, because there's suppression of estrogen, especially when you breastfeed. So some women will choose not to or may not be able to. Their periods may return and it's very different for them. For those who may be breastfeeding for a year or so, you will end up with this much more vaginal dryness. So that's why you can have a C-section. And then you're like, why does my vagina feel so sore? Nothing came out of there. But it's a hormonally driven thing. And that can cause nerve issues. That can just cause splitting. It can cause, just general like rubbing dryness. So it can be a combination of a scar for some people and then tearing, but also if your birth has been particularly traumatic and you feel like a lot has been done to your body that wasn't safe for you, maybe you've had an emergency C-section you weren't expecting, you'll feel quite self-conscious about that. All these things, again, can very much play into this sort of protection mechanism that can then underline the pelvic floor. So that can be something that we have to address and work as well. So it's many, many things that can be going on.
And then I suppose lastly, I mean, we talked about loads there, I've actually learnt loads as well. So it's been really helpful talking to you just for this 40 minutes. I suppose, yeah, you mentioned earlier on about the trans and non-binary community and sort of, what else can be done and sort of access and support. What would you say about that?
Yeah. Well, I mean, if I'm really honest, I think as a medical community, we need to put our hands up and say we need a lot more training and there needs to be more training provided. I think, what I always say is that obviously being trans is also hugely broad in the sense of you may be choosing to live as, change your gender, but not necessarily have had any physical surgery. You may have had top surgery, you may have had bottom surgery, you may be in a relationship, you may be not. And so there is an awful lot to navigate there. I think what I would say though is, it's knowing that care is accessible for all. I think as clinicians, we need to be humble enough that we're learning on this journey. We may not always get it right. We may not always say the right thing, but we also need the trans community to help us and be willing to be vulnerable with us so we can learn as well, because it's a two-way street. But I would say there are certain centres that obviously are doing a lot more of the, transgender reassignment surgery, which will have obviously more trained clinicians there because that's the work they're doing. My personal setting, that isn't the case. And therefore, I don't always feel the best equipped. So I might say to someone, look, I want to support you, but I don't necessarily feel like I'm best to support you. But I can suggest da-da-da. And we need to understand that as a clinician, who we are best to support. But I think, as the transgender community maybe feel they can talk more about their experiences or are starting to acknowledge the problems that they're struggling with, I'd say be brave, try and reach out. I think we're trying our best to try and adapt our clinical practice so we understand as much as possible. But it's a lot of us learning. There's new surgeries coming out all the time as well. So it's a lot of like, okay, so how's that going to affect physiologically what we're trying to work with and working from there. But it's sad because we don't even if we look at gender as a whole, we're not really even managing to treat women particularly well. We're very much in pelvic health doing a very bad job at looking after men and children. By the time, you feel like, oh gosh, well, we're completely failing the transgender community, but we're also not doing anything particularly well. So I will acknowledge that 100%.
Yeah.
There is a massive desire from our community that we want to be better. There's also an acknowledgement that we've got to learn together, and that's going to take vulnerability from both sides.
Yes, absolutely. I suppose finishing up, is there anything, is there any myths about pain that we need to debunk? Pain and pelvic floor that we need to debunk.
Yeah, I think the main one is that all pain will come from a tight muscle.
Yeah.
And it's just not that simple. It's much more sort of neurological, understanding the nervous system and the relationship with muscular change, and on the skin level. That's, I think, my biggest thing. It's almost like, if you just come to a physio, they'll release your muscles, all your pain will go away.
Yes.
Very, very unlikely. And it comes back to that biopsychosocial model of like, we are just more complex humans than that. And so I think people understanding that we will help you with your muscles, but we will also need to have conversations about other bits in order to ensure, and I always say this, I'm only having this conversation because I want you to get better. And I know if I can have these conversations and we can really dig deep here, the chances are we're going to get you better.
Yeah, absolutely. Well, I think, having somebody like you and being able to refer and kind of refer back and having a holistic approach, like you say, is so reassuring. So it's been absolutely wonderful having you. Thank you for all of your insight. It's been fabulous. Thank you.
You're welcome. So great to chat.